I'm Emily Jonas. I'm one of the ED Crit Care docs here at Christ, and I'm going to be talking about hypoxemia, specifically in ARDS patients. We'll touch on a few kind of general treating hypoxia topics for a very, very brief period of time. This is a big talk. It's hard to go through all that encompasses ARDS management in these complicated patients, so I'm going to do this in a case format, and I'm A-okay with active participation questions going along the way. So I have no disclosures. So the case we're going to talk about is modeled after a patient I had when I was a fellow. So a 34-year-old woman coming in with flu-like symptoms 24 hours prior to presentation, and her presenting complaint is dyspnea. She's 5'5", and that's going to be important later. Her temp is 38.3, heart rate 122, she's tachypnic at 33, and she's significantly hypoxic, and she remains hypoxic despite putting her on a non-rebreather. So testing-wise, she comes back positive for flu, confirmed influenza, she has a leukocytosis, and her initial ABG is as note. So on that non-rebreather, she still has a very low PO2, which is in line with her saturations. So you get an image after she's intubated, obviously, because there's an endotracheal tube there, but this is her chest x-ray. And so this is very typical of the imaging that we'll see in patients with really severe ARDS. So because she was still very tachypnic in the emergency department, she got intubated. A couple of the things I want you guys to keep in mind is high flow nasal cannula has a lot of really good data for treatment of hypoxic respiratory failure and should be a go-to if you think you can manage somebody without intubating them. She was very tachypnic. Her work of breathing is going to preclude probably utilizing high flow nasal cannula because she's probably not going to respond very well. But that isn't an option. And then another option is CPAP. And those are totally separate lectures. I mean, they're lectures in and of themselves, so we're not going to talk about that today. Initial vent settings. The thing I want you guys to look at first when you walk in a room with a ventilator is what is the tidal volume? And her tidal volume is 500 cc's. And I can already tell you, in a 5'5" woman, that's not even 8 cc's per kg. That's probably closer to 10. So she's got a set rate of 20. Her FiO2 is 100% in PEEP of 5, which is really typical settings that we see when somebody's first intubated. It's 5 of PEEP, 100%. And then we titrate from there. This is her initial ABG on those vent settings. One thing to note, she is a little bit hypercarbic despite your very high tidal volume and respiratory rate, and she's still hypoxic, although PO2 is above 55. Plateau pressure is 36, and so with a PEEP of 5, her driving pressure right now is 31. Which implies that she has horrible compliance. And so that's the other thing that I want you guys to start looking at too when you walk in the room is check a plateau, look at the PEEP, and determine what the driving pressure is. And we'll talk about why that's going to be important in a little bit. There we go. So in terms of diagnosis, because one of the things that came out of a study from 2016 in JAMA was that we under-recognize ARDS, massively under-recognize. 50% recognition for mild ARDS, 60% overall, and only 78% recognition in severe ARDS. So somebody with a PF ratio less than 100. So this lady has influenza pneumonia, and she has ARDS. ARDS is never the primary diagnosis. There's always something driving the ARDS. You can have ARDS and you always have ARDS and something else. So just because you say they have bacterial pneumonia does not mean they do not have ARDS. And so the Berlin definition came out to try to help us diagnose this more easily and try to help people better diagnose and recognize ARDS so we can treat it early. And so there are basically 3 components to this. And the 3 components are it must be acute. You must have bilateral changes on the chest x-ray. They actually say 3 quadrants. So your uppers and lowers, you have 4 quadrants. And then you have to have a PF ratio of less than 300. Okay, so it's actually a really simple definition, which is really nice because the simpler we make it to diagnose and recognize, the better we can treat it, the more active we can be about trying to improve people. So initial plan. The first thing I want all of you guys to do is calculate what their 8 ml per kg predicted body weight is. And you need their height to do this. It's a simple calculation, or there's a calculator built into Cerner, or there's about 1,000 of these charts on the internet if you just Google ideal body weight. So her 8 ml volume is 450. We know she was hypercarbic, so we know that we're going to make her a little bit more hypercarbic when we drop her volume, but that's okay. So we get her down to that, increase her respiratory rate, and we increase her PEEP. And so the very next thing, the other thing I want to stress on you guys is these patients need frequent reassessments. Just like volume reassessments, you need to frequently reassess your ventilator and what's happening with your lung compliance. And so next ABG, We're ventilating her a little bit better. Her PO2 went up a little bit with the increased PEEP. Her plateau pressure went up significantly, and that's kind of a scary number, 41. That's really high. We aim for 30, right? So if you calculate out her driving pressure actually with this, her driving pressure on these settings is 29. So it actually got a little bit better, even though the plateau pressure looks a lot worse. But the compliance is still absolutely terrible in her lungs. So now we're going to decrease her to that magical 6 ml per kg number. And we're going to increase her respiratory rate because we know she's going to get more hypercarbic when we do that. And we're going to increase her PEEP again. And then this is your repeat gas. We maintained our ventilation overall, and her PO2 is much better. Now her plateau pressure is 30. And on 16 of PEEP, now her driving pressure is 14. So the one thing I want to stress is looking at both the plateau pressure and the driving pressure. The plateau pressure is sort of the old school way of approaching the system. This is the ARDSNet 25 years ago now way of approaching compliance in the lung system. Driving pressure is the new kid on the block, and it has a lot of more recent data. There's a study in New England Journal that actually showed that the mortality correlates with driving pressure, not with plateau pressure. So I want you guys to frequently reassess the ventilator and check driving pressures on these patients. So we're going to talk a little bit more about what the driving pressure means because that's sort of the crux of my talk. But at the end, I'll give you guys a few take-home points as well. The next thing I want to just briefly go through, and again, this is a talk in and of itself, but the other therapies that we should consider in these patients, prone positioning. We should be aggressive about using this. It has good data in early treatment of early management of ARDS. So, and it's actually fairly simple. We actually implemented manual proning here, and I think the nurses have universally felt like it really wasn't as bad and as complicated as potentially it sounds. Paralytics have good data as well. And the one thing that I want to mention here is that paralytics are not required to prone somebody. You can paralyze somebody and prone them at the same time, but you don't have to keep them paralyzed to continue to prone them. So if you do the 24-hour paralytic protocol, and then you decide that they don't need to be paralyzed anymore, but you want to prone them still, that is perfectly fine, as long as you maintain a good sedation level. The other things to consider, we use inhaled nitric oxide here, but some PA vasodilation, something to try to improve your VQ matching, is also a reasonable therapy to try. So we use nitric because we are able to get it at a decent cost. Iloprost is the other medication often implemented in centers that can't afford nitric. So employ this. The one thing I want to make sure I mention about this is it's fast on, fast off for a reason, and that's why we use it, because it can make VQ matching worse. So sometimes it gets better, sometimes it makes things worse. Frequently reassess the patient. Diuresis is the other thing that I want to talk a little bit about, and these guys kind of talked about fluid management, and I'm going to talk about the opposite here a little bit. So we all know these patients have pulmonary edema. The pulmonary edema is not coming from cardiogenic causes. So it's not overt hypervolemia that's causing this pulmonary edema. It's non-cardiogenic. It's from inflammation. It's from whatever process is causing that, driving that ARDS in their body, their pancreatitis, their infection. And so when we go to diurese these patients, they often have received fluids and many of them are volume overloaded. But before you diurese them, I want to make sure that I stress the importance of a volume assessment in these patients as well, because you can intravascularly deplete these patients if you're not conscientious about their actual volume status. The other thing I want to talk briefly about, and going back just to the gases, oftentimes we'll still see, even with really high rates and our ultra low volumes, a pH in the 7.15 range, pH in the 7.2 range. And that's acceptable, and I encourage you to allow for permissive hypercapnia. But one way that you can try to eliminate some of that hypercapnia and makes everybody feel a little bit better when the numbers look a little bit better is eliminate dead space from the vent circuits. So the ventilator circuits, we almost universally use HMEs, and those HMEs come with extra tubing in addition to the HME itself. That HME and that tubing together are 150 cc's of dead space in your circuit. So we recently had a woman who was 5 foot that had ARDS, was on ultra low tidal volumes. She was on 4.5 mLs actually per kg at one point. And she had incredibly acidotic blood, pH of 7.15. I removed these two items from her circuit and we put her on a heated circuit instead, and her pH went from 7.18 to 7.30 with just that intervention. So this is another trick to employ when you're trying to ventilate these patients who have large dead space fractions, and you're allowing for some permissive hypercapnia. Eliminate that from your circuit. So now I want to touch on my personal favorite topic, which is driving pressure. And so the reason I like this is it has good data to show that our outcomes, our mortalities are better associated with this and with our plateau pressures that we're used to measuring. It's a surrogate for the lung compliance, which tells me, am I helping these lungs? Am I improving compliance in the system? Which is super important in these patients. And one of the things we're trying to get at is, can you recruit alveoli? Can you spread the pressure that the lungs are seeing over more alveoli so that each individual alveolus is under less pressure and under less strain? The goal is less than 15, and this comes from a couple of studies that showed an inflection point here, where your mortality, if your driving pressure is above 15, is in favor of death, and your mortality below with a driving pressure below 15 is in favor of survival. So that's where this goal of 15 comes in. So really quickly, just to illustrate recruitability in a couple of ways for you guys, we have two alveoli that are collapsed, atelectatic, and we're trying to improve this ARDS patient's lung compliance by recruiting alveoli. In a patient who is recruitable, what you'll see is the driving pressure is going to go down, indicating that the compliance is improving in the system, and this is what's happening. So this alveolus pops open, and now that's participating in gas exchange in your lungs, as opposed to not participating when it was atelectatic. In a patient who's not recruitable, when you go up on that PEEP, instead of popping open the alveoli, you're going to over-distend the alveoli that are already participating, and you're going to potentially cause worsening injury. And what you'll see is in this patient, the driving pressure is going to go up, not down, when you titrate up your PEEP. So this is kind of what we're trying to get at, is how do we best help our patients? How do we tailor the vent settings specifically to each individual patient? And Gatnoni did a lot of the early research on recruitability in the lungs, driving pressure. He was kind of sort of start looking at this. This is from his study that they looked at recruitability of the lungs doing a recruitment maneuver in a CAT scanner, which is pretty interesting. So they put somebody into the CT scanner with PEEP of 5, and then they put them up to 45 of PEEP, and they rescan them. And so 45 PEEP is a scary number. They're not maintaining these people on 45 of PEEP. It's a very brief period that they're on 45 PEEP, and then they drop them back down. But what they're trying to do is see, can you recruit those lung units? Can you recruit open alveoli? And what you'll see is in this patient, there's a ton of lung that is just not participating. And this is where his baby lung concept comes into play. This is the baby lung that's participating and that's functioning as a lung. And this is all non-functional lung that's not participating. And this patient is very recruitable. So you see after they get 45 of PEEP, all those alveoli pop open. And so that patient is going to really benefit from increased PEEP on their ventilator. They're going to have lower driving pressures. They're going to have a better outcome most likely. This patient is not recruitable. So this patient's lungs do not change with the application of really high PEEP. This patient is going to have an increase in their driving pressure as you titrate up PEEP and is not going to benefit from the increased pressure in the system. You're just going to over-descend good alveoli that were participating. And so this table is really busy. It's ultimately not important, but basically the table is just the data that I fed into these graphs. And so I want to graphically show you, just to kind of drive home the driving pressure concept, is as we titrate up the PEEP, what you'll see is one of two things. So as we titrate it up from 5 to 12 to 16, that driving pressure came down. The patient's lung compliance improved. The patient is going to have a better, is going to have more functional lung units and likely have a better outcome if we can get them to a lower driving pressure. And so titrating up the PEEP was beneficial to this point. Beyond this point, what you see here is that driving pressure starts to go up. And so we know that for this specific patient, 16 of PEEP is sort of the sweet spot for them currently with their current compliance in their lung system. And that's going to be different for every single patient. I'm sorry, guys. And so that's why it's important to measure these numbers on every single patient, because everybody's going to be different, their compliance is going to be different, and the amount of diseased lung is going to be different. Another way to look at this is by looking at the volumes too. And so the tidal volume is super important, and that's why low tidal volume cannot be stressed enough. This is the trend. You'll see the rising PEEPs here. And so you see on 8 mLs per kg, their driving pressure was quite high. And what you see when you drop them down to that 6 ml volume, actually the rising PEEPs is sort of going down. So it's upside down. You have to think about it in reverse because the driving pressure actually dropped. But So a bit of a difficult concept. But what you see here is on 6 mLs, this patient's driving pressure is significantly lower. And then as we titrated up that PEEP and that driving pressure went down, we got below that magical number of 15. And so for this patient, we found that 6 mLs and 16 of PEEP was sort of a magic spot that gets them below that cutoff to survive. This is also, the other thing that ARDS stressed is that 6 mLs is not the floor. It's the starting point. And so 6 mLs per kg or lower for every single patient with ARDS. Now, if you still have driving pressures that are really high, and you've tried to optimize their PEEP and you've done everything that you possibly can, dropping their tidal volume might be the answer for that patient. And so then you can start to tailor the tidal volumes too. And so we recently had somebody who was on 4.5 ml per kg, but because to get her tidal volume or her plateau pressures and her driving pressures down to a reasonable level, she needed 4.5 cc's per kg. And so driving pressure, I think, is a way that we can better tailor treatment to each individual patient, just like we're trying to get at individual optimizing fluids for each individual patient. Our vent settings should be individualized as well. And so that's where I'm going to hold, and then I want to just open briefly to a few questions because I know it's a big topic.